Hi, yeah. So my name is Hershel Dobkin. I'm a dermatologist in Columbus, Ohio. I want to thank the organizers of this symposium for inviting me to speak about acromegaly and how it shows up in the skin. I mixed in some things to spice this presentation up a little bit. Some of my artwork. It's my therapeutic release from clinic. I hope you guys enjoy it. This is the zebra unicorn. Okay, let me just. Okay, so I have no conflict of interest that are relevant to disclose. So this is the tree of life with a monkey inside. So the overview, just a brief physiologic mechanism of acromegaly to set the groundwork for how it shows up in the skin. Hopefully it's not too redundant. Some causes and the meat of the presentation, which is dermatological or skin manifestations of acromegaly, and some things you could do about it. And I made this so hopefully that it can be understood by anyone in or outside of medicine. But I'm happy to clarify things at the end. So the general mechanism, acromegaly results from persistent hypersecretion of growth hormone, which in turn stimulates the liver to release IGF-1, which causes most of the clinical symptoms. There's a simplified diagram on the right. Long term, this generally results in overgrowth of many tissues, and we're going to discuss how it can involve manifestations in the skin and skin appendages. The most common cause of acromegaly, which many of you are probably aware of, is a benign adenoma in the pituitary called a growth hormone cell adenoma. Other genetic syndromes exist. Perhaps some patients in this room may be aware of some of these. So these are the most common skin manifestations of acromegaly. Skin tags, increased hair growth, oily skin, acne, large pores, hyperhidrosis, which is the medical term for excessive sweating, and psoriasis. There are certainly other manifestations which I'm happy to discuss at the end, but these are the most, uh, by far the most common and definitely treatable things. So in terms of skin tags, they come in all shapes and sizes, in different colors, textures. On the left, you see more pigmented skin tags. Medical term is acrocordons. Um, and depending on your skin complexion, your ethnic background, they can look very different. And these are just some pictures to help visualize. And in terms of treatment of skin tags, before we even get to the treatment, I like to talk about prevention. Healthy body weight can definitely help, reducing friction in high risk areas like body folds, specifically neck, armpits, groin. Um, and the two most common ways we treat them in dermatology are scissor snipping, and we'll get into that in more detail, and liquid nitrogen, also known as cryotherapy. I also wanted to give a practical disclaimer because I like to avoid surprises in clinical practice, and it's good if patients come into an office being aware of this. But generally, skin tag treatment is considered non-medically necessary because they are intrinsically benign tumors or growths. And cosmetic because they do not pose a medical harm to patients and would be treated due to appearance concerns. The definition of cosmetic treatment is you treat for appearance, not medical necessity. So as a result, it's usually out-of-pocket expense and insurance isn't covered. There are some exceptions, such as already traumatized skin tags that do pose a risk of infection and can therefore be documented as irritated or inflamed. But many insurance plans do still deny these, and patients are left after the fact with large bills. So it typically should be treated cosmetically just to avoid any surprise bills later on. And before I even get to the treatment again, I like to discuss how you prevent complications because in a busy dermatology office, sometimes there's not enough counseling. And I always, go through this in great detail, but proper wound care is number one, which involves no picking after they've been treated and avoidance of neosporin because contact allergies are very common and it does slow wound healing. It doesn't prevent an infection in a person with a normal immune system. And appropriate procedure selection is critical because um, based on your different skin type, you can be more high risk of complications. Patients of darker complexion do tend to heal with temporary or sometimes permanent dark or light spots, which we call post-inflammatory pigment alteration or PIPA. This is more common with liquid nitrogen because of a larger area that's sprayed. It's less evident with scissor snipping, and I'll go over that in more detail, but because skin tags are often on a stock, the surface area that you treat is just snipping the base. So this must be just be considered. And there are ways to prophylax patients to decrease risk of pigment complications. There are skin lightening creams like hydroquinone that some dermatologists would tell you to use 2 weeks before and 2 weeks after, or various weeks. I would advise extreme caution with home skin tag removal kits. I see these every week. Patients who use these, it's one, there's a lack of sterilized equipment. The chemicals are not FDA regulated. There's a big chemical burn risk. As you can see below, this is a patient who had a post-inflammatory hyperpigmentation from liquid nitrogen, and she either did not use a skin lightening prescription before and after, um, or possibly she was in the sun too much after the procedure, which these are typically entirely preventable with patient selection, procedure selection, etc. And I wanted to include the Fitzpatrick scale of skin type. Generally, when I talk about different complexions of skin, in dermatology, we measure it in types 1 through 6. It's based on how easy you are to burn and tan. Patients with skin types 4 through 6 are generally at the high risks for having cosmetic complications of pigment issues, and you have to really cater your treatments towards that. So with scissor snipping, it's the most common way. You use a local anesthetic, such as lidocaine with epinephrine. We use sterile scissors, and the base of the skin tag is often electrodesiccated or burned, quote unquote, to decrease the risk of recurrence. You must inform your doctor or your provider if you're pregnant, because you should not use epinephrine in an anesthetic. It shuts off or slows blood flow through the umbilical cord. And if you have a pacemaker, in order to you have to use a different cautery device. It doesn't use electricity. Typical wound care involves just daily application of petroleum jelly, Vaseline, or Aquaphor with a bandage until you're healed. Typically, it's 1 to 2 weeks. And no picking. I always say the cardinal sins of wound care are picking and using Neosporin. And I'm happy to answer more detailed questions about that then. And those are some pictures about the procedure. Liquid nitrogen, also known as cryotherapy, it doesn't require local anesthesia, so patients who don't want to get stuck often choose this. It feels like a cold burn that quickly goes away. It's only skin deep, doesn't penetrate to nerves, arteries, muscles. I call it the ice cream spray, especially around little children. It creates a blister within 1 to 2 days that heals ideally without the skin tag, but larger skin tags may require multiple treatments. Must not pick or scratch. I know I keep harping on that. And the same with wound care, as I mentioned before. The next manifestation of acromegaly in the skin I like to discuss is hypertrichosis, or increased hair growth. In female patients, you can more accurately classify this as hirsutism, which is defined as excessive hair growth in a male distribution on the face, chest, and back. There's a cartoon on the right showing this and a clinical photo, just to help visualize. For treatment, the gold standard is laser hair reduction. Laser hair removal, which traditionally was used in the past, has gone out of favor largely in the dermatology and plastic surgery world because it may mislead expectations due to the need for long-term retreatments to maintain clearance. The provider or doctor must use an appropriate laser device based on the patient's Fitzpatrick skin type. Generally, Fitzpatrick skin types 4 through 6. Patients of darker complexion, certain devices are totally not safe and would definitely cause burning and pigment problems. Laser hair reduction, it requires 6 to 12 plus sessions for optimal outcome, but it may need periodic touch-ups. Electrolysis is okay, but it's generally less effective. I often don't recommend it. I am trying a home IPL device that I got on Amazon, but it's unclear if it works. I can't confidently recommend it to you guys. And there's non-permanent solutions. There's one prescription FDA approved called Vanica. It just inhibits an enzyme in hair growth that kind of smooths things out, but it's pretty pricey. I'm not a big fan. The one oral medicine that does help unwanted hair growth is spironolactone, invented as a blood pressure pill, but in dermatology, we use it for acne, we use it for unwanted hair growth. It's typically reserved for females, patients with acne or extra hair growth, or those transitioning, typically male to female transition, due to its anti-testosterone and androgen effects. And it's usually well tolerated. And another disclaimer, but laser hair reduction, it's also considered cosmetic. However, there are exceptions, such as for those transitioning in some cases, but many insurance plans still deny them. If you really want to get it covered by insurance, your best bet is your local or whatever you have access to academic institution. In Columbus, I would tell patients to refer to specific colleagues at Ohio State University, go Bucks, or in Phoenix, where you guys are, probably Mayo, um, or just any local like university center. So next we're going to talk about acne, oily skin, large pores. These are just some clinical photos of patients with dilated pores and oiliness, but I assume you all know what acne looks like. Comes in all shapes and sizes too, of course. Um, so for acne, for oiliness in large pores, topically, the best way to treat them is with retinoids. So retinoids, they do increase collagen production. They shrink oil glands, which medically are called sebaceous glands, and they unclog and they reduce pore size. There's a million other mechanisms, but they're the gold standard to treat this, and they're also anti-aging. But there's a lot of misconceptions about retinoids versus retinols. Retinols are over the counter. They're not FDA approved to treat photoaging. They're less irritating, but they're not an active ingredient. They need to be converted on the skin to their active form, which is retinoic acid or retinoids. So they're generally okay around the eyes because other prescription strength ones are typically too irritating. Retinoids, prescription strength ones, are 20 to 100 times more potent. The ones that are available now are tretinoin, adapalene, tazarotene, trifarotene. And there's different ways to get them covered by insurance. And there's various specialty pharmacies we use because when you're above 18, they often get denied. And but most dermatologists should be aware of ways to get them at an affordable cost. And they all differ in their strengths and tolerability. Um, the most tried and true one is tretinoin. Just has the most historical and literature evidence to back it up, its effectiveness. Um, Oral medicines we use for more extreme cases of acne or just patients who fail topicals. The most common is isotretinoin, also known as Accutane. That's the brand name. It's government controlled via an online monitoring platform called iPledge. Frequent blood work is required. The reason why it's monitored by the government is because historically it would cause severe birth defects if a person would get pregnant while taking, and for 1 month after the last pill, because it lasts in your system for a while. But it's typically given at a 4 or 6 month course. Patients who cannot get pregnant or just men, some dermatologists will give you low dose isotretinoin, like 1 pill a week, as opposed to once or twice a day. Um, I often have to do this for my bodybuilder patients who are on testosterone therapy. It could be similar to a patient with acromegaly. In residency, I had a patient with acromegaly who was on low dose isotretinoin and did great. It's well tolerated at low doses, but it does require blood work, and not every dermatologist is comfortable with low dose therapy. Most require monthly visits, but I do that for some patients. Acitretin is not government controlled, but it works very similar. It's also called Soriatane. It was invented for psoriasis and a similar risk profile, but this is reserved for patients who cannot get pregnant as well because it remains in your fatty tissue for 1 to 3 years. And some cosmetic procedures can be used to treat oily skin, large pores, acne. There's semi to permanent ones available. In general, whether you're going for lasers, microneedling, or peels, they often require a series of 3+ sessions for optimal outcome. And again, just like any cosmetic procedure, always ask your provider or physician which is safe in your skin type to avoid complications. They should all also be aware of this, but it's good to kind of hammer that point because we see it all the time. Mostly with med spas, and some offices are run by non-dermatology or plastic surgery providers, and it's kind of gets a little sticky from there. The most expensive option is resurfacing lasers. They're the most effective. Generally, it's around $1,000 a treatment, but it is pretty permanent. Microneedling is safe in all skin types, so that's a good one to do for pore size, scars, acne. Not so much oiliness. Chemical peels kind of help for everything. They're the most cost-effective option. various strengths. I love chemical peels because they're easy to do, um, and they're much more affordable. And many community dermatologists, they may not possess all devices, but most are happy to refer patients to responsible colleagues for these treatments. So I would always recommend ask for a referral if the office you go to just doesn't have whatever procedure you wish to have. In terms of what I would recommend, I'd recommend starting with a chemical peel for oiliness or large pores or acne. And if that doesn't work, you can always go to certain lasers. If you have a lot of scarring or just, yeah, mostly for scarring and really large pores, you'd probably want to go for microneedling, but you can always combine them. So next, we're going to talk about excessive sweating, or hyperhidrosis is the medical term. This is just a picture of sweaty hands. Um, so in terms of treatment, first you want to try to avoid triggers if you can. Not everyone can, but stress reduction, looser, non-synthetic clothing, like not too much of the polyester compression garments, avoiding spicy foods if that applies, alcohol. But topically, some dermatologists would start with Drysol, which is an aluminum chloride compound. It's minimally effective and it's pretty much the same as we can get over the counter. I would always, if you want to treat topically, the most effective is something called Qbrexza. It is the only topical medication that's I would say is very effective for excessive sweating, but it is only FDA approved for what's called primary focal axillary hyperhidrosis, which in English or patient-friendly terms means sweaty armpits. It's if a dermatologist would prescribe it for just general hyperhidrosis or uh, sweating of the palms or soles, your feet or your hands, it would get instantly denied just because their insurance companies are very strict about prescribing on label. But it can be used in other areas of the body. A unique quirk about this medicine um, is that if it comes in a cloth, and if you were not to wash your hands after putting it on, it would dilate your pupil, and everyone would think you're having a stroke. So you gotta be careful. And that's happened multiple times. But a lot of reassurance. It doesn't affect your vision, but I would tell patients if you're putting it on your armpits, wear a glove or something, and then take the glove off after you're done applying. But that's a very effective option. It's typically $50 for month supply if it's denied by insurance, because specialty pharmacies are in generally every state that can accommodate it. Oral medicines, which I think are the mainstay of treatment for this, most effective I think is glycopyrrolate or Robenal. It's usually well tolerated, but it generally stops or slows secretions in any organ, so that's where side effects come from. Usually no one has any side effect at all, but if you can imagine slowing secretions everywhere, you get dry mouth, dry eyes, constipation, trouble urinating. Um, so yeah, that's something to just keep in mind. But we give it at low doses compared to what they give like in a hospital setting for like a critical care patient. They give them at a very like IV medicine versions, and it's much higher. Oxybutynin is a second line, very same class of medicines as glycopyrrolate. Sometimes I use that when you get some response but not effective enough. When oral medicines fail, topicals fail, Botox is actually FDA approved for the sweaty armpits or primary focal axillary hyperhidrosis. It's safe and relatively painless if performed correctly. When I say correctly, I mean with ice packs and numbing cream. And you can even do Botox in the palms and soles painlessly, but sometimes not every dermatologist will do it. Uh, it's temporary, it generally lasts 3 to 6 months. And this is an example on the right. I call it the diamond shape because the area where your sweat glands are most concentrated are in that area of your armpit. Insurance coverage is possible, but your best chance of getting is through an academic institution. They have better just coverage support. Um, Sometimes if a private office tries to do it, the medicine itself gets covered, but the actual procedure doesn't. It's kind of like if you were to need like a hip replacement and whatever implant they're trying to put in gets covered, like the actual metal thing or rods, but the surgery itself is denied, which doesn't make any sense, but that's just the reality. Um, so yeah. And other device treatments are actually like iontophoresis a lot. It uses an electrical current to inhibit sweating. It is pretty painless. I actually just came back from our annual dermatology conference in San Diego, and I tested out this Dermadrive device, and it just feels like a little skin prick like prickliness sensation, like static. But it works, and it's something you could do at home. And there's always Black Friday deals and discounts. So even though it says 500 there, it lasts for many years, and there's always discounts. Dry is another company, but Dermadry is the most tried and true. You can put your feet in there, your palms, but they make pads that you can put in your armpit. The other one that historically was used but has gone out of favor is a sympathectomy. It's the surgical interruption of your upper thoracic sympathetic nerve chain, which controls sweating and other things through either cutting, clipping, or something like that. It's rarely performed because there's a ton of complications and it actually questionable effectiveness. So getting to psoriasis, psoriasis is a chronic autoinflammatory, not accurately called autoimmune disorder of skin with genetic and environmental basis. It's unclear if acromegaly causes psoriasis or just it's associated. The way I like to describe this, it's kind of like patients with eczema. They're more likely to have asthma than the average patient, but it's not that asthma causes eczema. The gene loci are probably just located close together. And these are just clinical examples of what psoriasis looks like. It looks different, skin types and different severities. Um, uh, Before we even get to the treatment of psoriasis, I like to discuss what's the risk of not treating. So when you have moderate to severe psoriasis, which generally some may say it's 8% or 10% body surface area, it has been associated with a high risk of leukemia, lymphoma, or coronary artery disease due to the chronic unopposed inflammation that's circulating throughout your body. So, moral of the story, we know patients based on the data live longer and are healthier if their psoriasis is treated. Also, very important because this comes up frequently, mostly in the inpatient side, oral or systemic steroids should be avoided in patients with psoriasis due to the risk of a life-threatening rebound flare of what's called erythrodermic or pustular psoriasis, which basically is a head to toe. Your psoriasis would be head to toe, you'd be all red, and your kidneys would be at risk of failing, and a whole bunch of other things. And this scenario comes up a lot when patients go to an urgent care or ER for their psoriasis, and they get prednisone or even goes for another reason like a poison ivy, and they're given prednisone and their psoriasis clears, but as soon as they're off prednisone, they get this rebound flare, and this happens the majority of the time. If you have a life-threatening reason why you need prednisone, definitely gotta go for that, like an asthma attack or a COPD exacerbation. So in getting to the treatment, the non-medical treatment is narrowband UVB, which is a safe wavelength that doesn't cause skin cancer or melanoma. It's a vertical looking tanning booth or time machine like thing. And this has good insurance coverage. But some patients they like to go to like a local tanning salon, but unfortunately those can be known to be carcinogenic and you'd be at risk of melanoma or other non-melanoma skin cancers. Topically, steroids traditionally were the mainstay of treatment, but we're in a renaissance now of non-steroid topicals that are very safe. Vitamin D analogs like calcipotriene are available. Tacrolimus, pimecrolimus. The newest stuff, the new kids on the block is Zoryve or roflumilast or Vtama or tapinarof. Don't ask me how they come up with these names, but they are effective, and most of these are very safe medications. There's only two oral medicines. Well, you can argue there's three because acitretin, I talked about earlier, is approved for psoriasis, but immunomodulatory. So Tesla is not immunosuppressive at all, doesn't require any blood work. It does a good job, but it usually never clears you completely. The most common side effect is diarrhea in about 10% of patients, but it usually does go away after the first month, but sometimes it doesn't. I'm not a huge fan, but it has its place. So TIC2 is really nice. It's an oral medicine that's immunomodulatory. Because psoriasis, it is an overactive immune system, essentially, disease, and this medicine controls that to a normal level. It doesn't shut things off, but it does require blood work and some monitoring. Some of the medicines I'm sure many of you have seen commercials about. There's a ton of them. Skyrizi, Humira, Tremfya, Cosentyx, the one with Cyndi Lauper in the commercial. believe it's Cyndi Lauper, maybe it's Bonnie Tyler, I forget. But these are typically needed less often. Cosmetics is eventually once a month, Skyrizi's every 3 months, and these will typically clear patients completely, both inside and out. Their joints would be feeling better, and their skin would clear. And these are my references, and that's a picture of a drawing of a Samoyed I made. It's my favorite type of dog. So I just want to thank everyone for their time, but I'm happy to answer some questions. Hopefully, this was practical and easy to understand.
Question, Penny? Do you have any suggestions for, my skin is so dry, which I believe is one of the side effects of acromegaly? Any suggestions for what helps, what the best treatments are?
Yeah, I wouldn't say there's just one. It's a great question. First, you got to determine if you're adequately hydrated. So generally, depending on who you ask, 2/3 of your body weight in ounces is the recommended daily water intake. So if you're a 150-pound person, 100 ounces of water, which is, I think it's a little over 3 liters. So most people definitely don't drink enough water. Your humidity in your house or where you live, you sleep, especially in your bedroom, should be, I would say, between 40 and 60%. And in terms of, but there's also medications that can be making people dry in addition to the acromegaly aspect. A lot of medicines do, like the ones for sweating, not just the ones for sweating. A lot of medicines do cause dryness. Some blood pressure medicines, especially if people are taking diuretics for blood pressure. But generally, hydration, controlling your humidity, moisturizing, that's definitely a critical component. It has to be at least, I would say, twice a day, definitely after you shower. Hyaluronic acid based moisturizers, I think, are the best. And there's different brands that have them. Um, you don't really necessarily need to cover yourself in Vaseline, but you definitely, after you shower, you need to lather up those dry areas.
Any other?
Thanks.
Yeah. There was a question online is about, can you do something about hyperpigmentation of underarms?
Oh, of course. Um, well, first, expectations. So first, you determine the cause of the hyperpigmentation. Um, for example, there's a common condition called acanthosis nigricans, which is associated with acromegaly, but also diabetes and other growth hormone related issues. So an accurate diagnosis is critical first. Sometimes someone could have an allergic contact rash that results in pigmentation in their armpits from deodorant. So first, you have to determine the cause. And if you're just left with plain old pigmentation, you have a few options. Generally, retinoids can be a good choice because retinoids control how make the skin turn over in a more controlled way to even the pigment. There are skin lightening medications with hydroquinone in it that can lighten the skin, but they often are pretty irritating. Um, if those fail, retinoids and just treating the underlying cause of the pigmentation, there is a medicine called tranexamic acid that neurologists should be aware of. It's used as the antidote, I think, for what they give for strokes like TPA, but we use it for melasma. And because in dermatology, we found out this medicine evens pigment and slows pigment production. And it's a very safe medicine, but has a small risk of blood clots, kind of like how much birth control medicines cause. But we can use that too.
Can you say the name of that again for the person that asked the question?
The oral medicine, tranexamic acid, it's TRANEXAMIC acid. Yeah.
Any other questions? No.
Are there side effects to retinoid?
So somebody asked, are there side effects to retinoids?
Yeah, so topically, it's mostly just irritation. And I'm convinced that as long as you properly counsel a patient, and I like to provide written handouts, which not everyone does, you can avoid all those side effects. And what that typically means is when you start a prescription retinoid, you should do what's called the sandwich technique. And 3 times a week, basically, you put a moisturizer on, rub it in, then use a pea-sized amount. You dot it on your face, you rub it in, and then always avoid the eyes. That's critical too. Only use over-the-counter retinols, weaker stuff around the eyes, unless you're feeling bold. And then put on another layer of moisturizer on top. Or you could just do the retinoid and moisturize on top. So you always have to combine it with the moisturizer and not every night. And wear sunscreen in the morning because sometimes they can make you sun sensitive. But yeah, it's just properly not doing it and you build up. Eventually you can use it every other night, then every night, but always use a moisturizer and avoid the danger zones of the face. Eyes, corners of the nose, and corners of the mouth.
Go ahead, yeah. Yeah, speak up.
Is there an increase of skin cancers, such as melanomas and just various skin cancers for people with acromegaly?
It's a great question. Generally, there hasn't been a definitive association, but with the comorbidities that the patients with acromegaly have, those can put patients at risk for skin cancers.
But you said they are at risk for skin cancers.
Yeah, so acromegaly doesn't directly make you at risk of skin cancer, but if you have untreated psoriasis, you could develop a higher inflammatory state that could lead to other types of malignancies. But it's the condition itself is not like definitively associated with higher skin cancer risk.
Do the skin cancers, if somebody with acromegaly, if they have different skin cancers, melanomas, do they tend to grow faster because of acromegaly?
It's a great question. There hasn't been like a study on it, and I haven't personally seen it in the literature or in clinical practice. The patients I saw in residency with acromegaly in New Jersey, they pretty much presented as any normal patient with the common types of skin cancer, whether it was melanoma or a basal cell, and it wasn't any more aggressive than your average patient, as long as you had a normal immunocompetent state, like a normal immune system.
Thank you.
There was one, I was gonna go to the chat and then we'll go to you. That's cool. There was one more in the chat. Is laser removal safe for acromegaly patients?
Oh, of course. You just have to determine the proper device, and if there's any prophylaxis needed with skin lightening medicines and adequate, you need to definitely have good sun protection. But certainly, it's not that the acromegaly itself is an issue. It's that the patient's skin type needs to be taken into account, and just proper, disclosure of everything you need to do to have a good outcome.
What about I know you didn't talk about this, but circles under your eyes and puffiness, because my bags under my eyes got worse, obviously. So is there any recommendation for that?
Oh, of course. So it's definitely, it can be challenging, but the best things to do would be start with some kind of retinol or even a low strength prescription retinoid. The lowest strength one typically I recommend is tretinoin 0.025% or adapalene, which is different, 0.1 or 0.3. So other things besides retinoids that help with puffiness are caffeine-based topicals. They help with its edema. If it's a fluidy puffiness, then caffeine-based things would help. I'm not saying to ingest more caffeine, just topically. Obviously, the last resort is plastic surgery, but I find that not as necessary as people used to think. Chemical peels sometimes can help. I generally don't recommend filler around the eyes to tighten things. One, it's temporary and it's very lumpy and bumpy, and I'm not a big fan of that. But did that answer your question?
Anything else?